Bien. Bonjour à tous.
Good morning, everyone. We're going to start this morning's session. Please, if everyone could settle down so we can start. Thank you. We're going to start this morning's session. As you know, if we look at skin NTDs, one of the impacts is everything linked to disability, the stigma, and mental health. And we are very well aware that suffering on a mental level can sometimes be even more significant than on a physical level. And we have to take into account the issues of stigma and mental health when we work. And this morning's session is going to be dedicated to the subject. And so to start our session, I would like to invite Dr. Wim van Brekel, who is going to tell us about the stigma and disability in relation to skin NTDs. Dr. van Brekel, you have the floor.
Yes. The Zoom hasn't started yet, I think. Huh? The Zoom meeting, has that started yet? Because I'm not getting the Zoom meeting.
Recording in progress.
There we are. A very good morning, ladies and gentlemen. It's a great pleasure to talk with you this morning about this important topic of the psychosocial and economic impact of skin and skin-related NTDs. You can see my name on the screen there. I work as medical director for NLR in Amsterdam. We are an international NGO focusing on the fight against leprosy, but also involved in various other NTDs, and especially looking at what are the cross-cutting aspects of NTDs. So let me see if I can get into the slideshow. There we are. Okay. Right. Yeah. Okay. Yeah. So next slide, please. Yeah. Yes, please. Yeah. So when we look at skin NTDs, and we've heard a lot in the past few days already about the disease complications, which may lead to disability, may lead to social stigma, to restrictions in social and work participation, and other forms of exclusion. And so these factors together, again, have a profound impact on the mental well-being of persons affected and their families, and have a serious economic impact. Next, please. So the challenges we face are first of all related to these actual consequences, you can say, as I've just mentioned, related to disability and stigma and mental health. But there is also the problem, which we heard something about yesterday, that the actual burden, the magnitude and distribution of NTD-related disabilities is not known. And whenever we do see maps of a particular NTD, it tends to focus on things that come out of maybe laboratory testing, such as seroprevalence. and there is very little data available about the number of people who actually live with the long-term consequences. And so we know that impairments such as nerve damage in leprosy or lymphedema require lifelong self-care. The care of complications, and such as wound care, are very fragmented in health services. And often those health services that are there are difficult to access. That may be due to distance, it may be due to the problems that people with specific disabilities face in accessing buildings, for example. Then there is the problem that at the higher level, the national level, if you look at it from a holistic perspective, the services are handled by different ministries. So we have the ministries of health, we have ministries of social welfare to deal with, Ministry of Labor, and so on. That requires the very difficult intersectoral collaboration. For those of you who have tried that, you know that that is a real challenge. Next, please. So we'll look first of all at the socio-economic effects of skin NTDs. Now it's looking for data, and that is actually hard to find. Even in the big studies such as the Global Burden of Disease, I could actually only find data on 3 of the NTDs, leprosy, lymphatic filariasis, and onchocerciasis. And you see there from the figures, the DALIs and the years lived with disability, that those are the same, which is because those NTDs are not known to cause mortality, and therefore those figures would turn out to be the same. But the main problem is that they are great underestimates of the actual burden. So there was a recent study done at Erasmus University on the leprosy disability weights, showing that for a grade 2 disability, which is the visible disability, the actual weight should be 4 times higher than what is used. And for grade 1 disability, which is sensory impairment, it should even be 20 times higher. But then for leprosy, it is also a big problem that it is incidence-based, and so the number of patients in a given year are counted for the duration that they are on treatment, which we all know is only is maybe 6 months to a year at the most, but for many people who do have disability or face socioeconomic consequences, that goes on for a very much longer period, and therefore the burden that we are faced with is very much bigger than what we see in those figures. For lymphatic filariasis, Ton and colleagues in 2015 published a study showing that if you take depression into account, the burden of lymphatic filariasis would be twice as high as what is currently published. Similarly, and even stronger for dermal leishmaniasis, Bailey and colleagues showed that it would be 10 times higher if the chronicity of dermal leishmaniasis was taken into account. There are precious few studies on the socioeconomic impact on the persons affected, or in reverse, the benefit of actually doing something about these problems. One paper that stands out is the one from Rao and colleagues in India, who calculated an indicator they called the years of working life lost. They examined a random sample of 150 people from 3 states in India, and they used as a reference 42 years of working life, so from 18 to 60. And they found that the overall mean disability-adjusted working life years was 28.6, which is more than 13 years less than the reference. And so their conclusion was that on average, 30% of the leprosy-affected person's work life is lost due to disability. Then there was an equally interesting study from Elizabeth Stillwagon and colleagues also in India, looking at the economic costs and benefits of lymphedema management. The average annual out-of-pocket cost of medical care for lymphedema and acute attacks was $14, or more than 10 times the average daily wage of an unskilled rural worker in the state. The estimates of the reduced time spent in on paid or unpaid employment ranged from 13 to 19%. And they concluded that together with the out-of-pocket medical costs, those earning losses are an extraordinary economic burden on some of the poorest people in India. And they also looked at the percentage of working days lost, and they found that when you try to correlate that with the stage of lymphedema, the people with stage 3 lymphedema had 20% loss of work days, stage 4, 50%, and stage 5 to 7, 100% of days, working days lost. Next, please. So let's try and look at these problems and try and understand how they come about and what a more holistic view of them would look like using the WHO International Classification of Functioning. First of all, if we look at the WHO Skin NTD strategic framework, the definition of disability is an inability to perform routine daily activities adequately or independently, and the negative aspects of the interaction between a person with a health condition and his or her context, especially the environmental and the personal factors. And it is especially that second, the interaction between the condition, you could say the physical condition often of the person, and the environment, which is especially important. So the ICF framework, which was published in 2001, is unique in the sense that it doesn't look at if a person has a given disability, what disease has caused this, like with the International Classification of Diseases, but it looks at what problem does the person face, regardless of the cause, you could say. And so that is an excellent point of departure for us when we look at what cross-cutting aspects we can find in the group of skin NTDs. So it starts with a skin NTD, and then the ICF distinguishes 3 areas of functioning. The first is at the body level, so body functions and structure, for example, vision, the lymph system, motor function, but also mental function come under that area. Then there are 2 domains that relate to functioning. One is from more at an individual level, so activities, mobility, dexterity, reading, self-care. And then there is probably the most important domain for the individual person is that of the interaction with other people, so roles in society especially. And that is in particular work and livelihoods, but also relationships, education, communication, social and civic life. And there's a whole list, and this is only a few examples. Then there's the domain of personal factors, such as gender, age, but also intelligence, spiritual life, and so on. Surrounding all of that is the environmental domain, so the environmental factors, to which also attitudes and behaviors, the discriminatory behavior would belong, but also infrastructure, water, sanitation, etc. Connecting all of these together, there are bidirectional arrows which show that all of these factors, they influence each other. Next, please. So when we now look at the impact then in the terms of the ICF, we first look at impairments, such as visual impairment, lymphedema, motor impairment, medical distress, depression. Here we see a typical example of a chronic wound in a person affected by leprosy. And some examples of lymphedema in lymphatic filariasis. But also, as I said, the impact on mental well-being. This is a study from Nepal looking at mental well-being and depression frequency among persons affected in South Nepal. They used the PHQ-9 to define symptoms of depression, and so up to a quarter of the people qualified for moderate or more severe depression. Close to 40% had poor mental well-being, and 50% had thoughts about self-harm or suicide. So impact on functioning. Can I just check? I thought I had 20 minutes, or is that, yeah, that's right. So in the impact on activity limitations and participation restrictions, and at the individual level that would be difficulty in walking, difficulty with dexterity, difficulty reading or in personal care. And at the social role level, unemployment, relationships that are affected, poor access to education, and restricted community, social and civic life. Next, please. Then there is impact of and on personal factors. And I'm just mentioning one example here. That is internalized stigma. And so when people have been exposed to negative attitudes in society or discriminatory behavior, they are inclined to internalize that and to start believing that they're actually worth less or that they're guilty of what they are suffering from. Then if we look at the impact of the environment, and there is again a whole range of examples that one could give, but especially I want to mention stigma and discrimination because that is often not realized that it's part of environmental factors. But when we look at the stigma or discrimination in society and also that which is experienced from health workers all too often, and that is part of the environmental factors, but also would be more structural or infrastructural issues like wash facilities, and also legislation comes into that same area. Then we look at approaches using a holistic and cross-entity perspective, again using the ICF as a framework, and that is then where the term DMDI comes in. That is by now already fairly well established. Disease management, disability and inclusion is a holistic approach for providing people-centered services in the NTD field. And so it includes this much better known concept of morbidity management and disability prevention, but is holistic and therefore focuses on inclusion and participation of persons affected, and notably it's also human rights based. So looking now at the ICF components in the original way that this was published, when we look at prevention of disabilities, that first of all engages with the domain of body functions and structures in interventions and services like wound and skin care, self-care or mental well-being support. But often it also needs to engage with the domain of activity or participation, such as for assistive devices like protective footwear, livelihood support and vocational training, so that people can get out of a vicious cycle where they have work that actually is damaging for their limbs. It may also need to engage with the environmental factors, such as when wash interventions are needed or poverty relief. Here we see some pictures from combined self-care groups in Nepal and in India, where people affected by leprosy and by lymphatic filariasis are sitting side by side doing limb care, but often those groups have also developed onto self-help groups where they work on their own development and through socioeconomic activities. Now then, physical rehabilitation, which is also a very important aspect and is often neglected, I would say, especially at the field level. That rehabilitation is focused on enabling people to optimize their activity and participation, but it often needs to engage with the other domains in the ICF, such as body functions like with physiotherapy or mental health care or surgery, or with improving activity through assistive devices, through training on how to live with certain disabilities or the use of adapted tools, And then lastly, there is the domain of inclusion, which is probably the most important domain from the perspective of persons affected. Self-help groups I already mentioned, or when they get organized together at a higher level, we tend to refer to them as self-help organizations or disabled people's organizations. Microfinance schemes play a very important role, sometimes in the form of saving schemes that groups may set up themselves, and with the purpose of actually improving livelihoods, improving employment. There may be work needed at the personal factors level, such as in education. A well-known example is adult literacy for those who have not been to school. Counseling to become aware of ways to cope better with the disability and even the mental well-being stress that people may experience. Empowerment is also a term that is often used when activities are undertaken to try and strengthen people's resilience. Then there is work in environmental factors such as advocacy for human rights or work on accessibility that can be physical through ramps or in the domain of water and sanitation. There is awareness raising, which is an important way of helping to reduce stigma, but certainly not the only way, and so other interventions are needed to reduce stigma and discrimination. This rehabilitation is best delivered to most of the people that we are actually thinking about in this conference through community-based rehabilitation, or sometimes, as this is known, disability inclusive development, which has the same aims as rehabilitation, but is realized through task shifting at a very much lower level at the grassroots, and also then involves physical rehabilitation, personal development, and attention especially for the environment. I think I reiterate that poverty reduction, stigma reduction, education, and promoting equal rights and opportunities. So some examples of cross-NTD initiatives have been combined DMDI and WASH project for leprosy and LF in Nigeria, integrated NTD-related disability mapping and strategy development in Liberia, Ghana, Ethiopia,
1 minute
Myanmar,
more, please.
And then integrated mental well-being care for people with LF, podoconiosis, and leprosy in Ethiopia, as we've heard already earlier. So then, in conclusion, millions of people live with lifelong consequences of skin NTDs and receive very little attention in NTD programs. Persons affected by skin NTDs face both physical, social, and emotional problems. The WHO ICF is a very useful tool to understand how this comes about and what can be done about it. And then maybe lastly, at the field level, community-based rehabilitation or disability inclusive development address the problems where the people live. Thank you, Chair.
Merci beaucoup, Dr. Vim.
Thank you very much, Dr. Vilm, for this very good presentation and for telling us about the socio-economic impact and the physical rehabilitation help that's available for the effects of the impact of skin NTDs on disability. And I think you said some very important matters. You told us about the work and that we all need to be able to offer these services in a holistic manner to our patients. Now we're going to move on to a second presentation, which is going to talk about patient organizations. And so I'd like to invite Jennifer Austin, who is going to speak to us about patient organizations as partners in the management of NTDs. Thank you.
Thank you, Mr. Chair. Okay. It's an honor to be presenting to you today. I'm feeling very humbled to be in this room and around this table. This has been an amazing week. My name is Jennifer Austin, and I'm the Chief Executive Officer of the International Alliance of Dermatology Patient Organizations, also known as Global Skin. And before I go to my first slide, I just want to thank you all for the work that you do in your countries. And what I'm here to talk to you about today is how we can help as patient organizations and patient groups around the world. And some of the themes that will be spoken about today and have already been spoken about today are really around the need for more education and support for patients or persons affected with NTDs. And the aspect of what I want to speak about today is really how patient organizations can help in education, and that includes with self-help for patients, but also in helping to address and minimize the stigma and discrimination that people are experiencing as a result of their diseases, and in terms of support, to be able to look at patients with a holistic approach, to look at the whole person, and that includes helping to support their mental health needs. Next slide, please. So just a little bit about the organization that I work for. So we are a global organization. Our headquarters is in Ottawa, Canada, but we have patient organizations in 67 countries and representing more than 55 disease areas across skin diseases. And we currently have more than 200 member organizations. So these are people that are working in organizations directly supporting people with skin diseases. And the vision of our organization is and I think you can all probably get behind this vision. I think we're really all here to do the same thing, which is to create a world where people with skin conditions are healthy and fulfilled. Wouldn't that be amazing? And you're all helping to contribute to that. The way that our organization is approaching this vision is in 3 ways. First, we want to elevate, and which is to say, help to raise up the organizations that are under our umbrella. And we do that in a number of ways, including helping to professionalize those organizations and build their capacity to do more of that education and support. We also champion the voice of patient organizations around the world. So we come to events like this and speak on behalf of all of those patient organizations that are part of our alliance. And then further, we work as catalysts to bring together the wider community of support around patients to unite, to have a common voice, and to work towards common objectives. Next. So I want to speak a bit about patient centricity first, and this is obviously about looking at things through the lens or the eyes of patients. And we were obviously very happy to see in the NTD roadmap this quote, which is to say, involvement of patient groups and people living with NTDs in designing NTD programs can empower them and ensure that interventions adequately cater to patient needs. So that's putting patients at the center, but also having them around the table like you see here today. There are a number of organizations that are working directly with patients that have been invited to sit in this room and indeed at this round table, and we're very thankful to the WHO for that. Next slide, please. So for our community, we want to see this patient-centric approach, and that will help to build insights, trust, connectedness, and channels that go directly to patients themselves. And we want to see engaged and empowered patient organizations to work as key partners in delivering health care, because we believe that will help to optimize the delivery of your programs, interventions, and supports to patients. So what is a patient organization? I'm sure many of you have worked with patient organizations or patient groups or self-help groups. They're called many different things, and they span all the way from very informal groups. Some may only be in one community, or they may be online. They go all the way from local, national, regional, all the way up to international, like organizations like ours and some of the other groups that are here in this room. And, you know, really, it's important to know what a patient organization does, and this is a description from Canada. And I think I looked around for descriptions, and this was the best one I could find. And basically, it's an organized group that's helping to represent the patients in a specific disease. And that can include not just the patients, but also their family members. Value that the value that patient organizations bring is quite multifold. So they can be part of policy making to make sure that policies are developed in a way that are meaningful and help patients and meet them where they are. Capacity building and education, that's helping to eliminate or minimize that stigma. It's helping to educate the patient themselves to be able to care for themselves and to translate information that perhaps in health systems you're working to share with patients, and patient organizations can help to translate that into words or language that makes sense to the patients. Also, research. Patient organizations can be very helpful in research, helping to provide you with channels to the patient, but also to help inform best ways to be able to involve patients in research so that they will actually participate. And our organization has a poster today. I hope you'll have a chance to check it out. Some patient organizations actually run their own research, and please have a look. It's called Global Research on the Impact of Dermatological Diseases. And then peer support. This is the patient-to-patient or persons-affected support to provide people with the help that they need at a community level. So I would encourage you to think about connecting with us or patient organizations. If you don't know who the patient organizations or groups are in your country, you can go to our directory at globalskin.org, and you can search by country and by disease. You can also do your own searches online, and you can also ask healthcare professionals or healthcare providers in your communities, because they may be aware of groups that are already in existence. But where there are no organizations or groups, we can be helpful in that. We have a toolkit to help patient advocates get started. We have micro grants that we provide to help with projects that they want to take on, and we do training and mentorship. And you can see on the right just a few of the organizations that are part of our network of over 200. There are many benefits to partnering with patient organizations. We help to identify the verifiable patient and community needs from the patient perspective. We also can help to harness the energy and knowledge of those patients to help others within their own communities. We can connect you with patients through our networks, and that's very helpful for things like research and perhaps for doing interventions where you want to be able to reach the patients. And we can communicate, which is to say also translate information in a way that is understandable and appealing to the patients. Where can this have the greatest impact? Well, patient organizations can help to identify and address education and support gaps. They can also support in health promotion activities, including capacity and awareness building, and to help create patient materials that from a layperson perspective. There are many positive outcomes in working with patient organizations, and I just want to say that everyone in this room is doing such amazing work, but we know that the challenges are huge. So patient organizations and groups can help. That's really the message that I want to convey today, that we are here, we have the same objectives, and we can be assisting you in the work that you're doing at the ground level. So what can we see as an outcome of that collaboration? We believe that you would save time, money, and human resources because you'll have the patient perspective when developing your interventions or your programs so that it is approaching patients and meeting them where they are. It will build trust with communities because they are of the community and for the community. They can be that conduit and to build that trust. It can also be very helpful to having patients opt into your programs because that trust is in place. And you'll meaningfully meet patient needs without injecting the bias of healthcare workers, which, I mean, healthcare workers are obviously very knowledgeable, but they are not living in the shoes of the patient. So you will have that firsthand patient experience and helping to inform what their needs are. And ultimately, we believe if all of this comes to fruition, that we will have improved outcomes and patient satisfaction. So our vision is to work with you, that if we want to meet the goals of the NTD roadmap, and we want to be able to control and eradicate NTDs, it can't fall just on governments. It can't just fall on health departments and public health officials and doctors. Patient organizations need to be engaged, and they can help to empower patients and build insights and help with education and connecting networks of patients. This will result in, back to that term I used before, that those patient-centric programs and policies. So how do we get there? So there are a few things that we believe can be done to assist with integrating patient organizations into this process. First of all, developing a framework where there can be meaningful and systemic engagement and collaboration. So opening your door and letting patient organizations know how they can connect with you, and creating the environment where it is it's going to work for everyone to work together. Supporting the involvement of patients and patient organizations and groups as equals. And again, looking around this table, seeing patient organizations participating fully in this WHO meeting is a great example of how you can incorporate patient organizations as equals at the table. And strengthening the dialogue between patient organizations and the healthcare sector. So helping to make those connections and to put in place those bridges to start the communication. And finally, helping patient organizations get started or helping to expand their capacity. And there are lots of ways to do this. Many of these groups are very grassroots and need help in getting started or in building their capabilities. We can help. We know there are ways that you can help, so please come and speak with us about that. So the take-home messages for today: close collaboration and co-creation with patient organizations will create trust and build credibility with patients. It will save time, money, and resources, take pressure off of healthcare systems, meaningfully meet patient needs, and ultimately improve outcomes and satisfaction among patients. I want to say thank you to a number of organizations. First of all, I want to acknowledge and thank the over 200 patient organizations around the world that we are working with to support people living with skin diseases. And this number is growing, and we hope actually from being at this meeting that we will see it continue to grow. We know that we've already met a number of organizations that are working directly with patients as non-governmental organizations, and we hope that they will join our network. There are a few of our members in the room today. Could you just raise your hands? So I hope at the next meeting you'll see a lot more hands raised because it's important for patient organizations to be present at meetings like this. I also want to say thank you to the International League of Dermatological Societies, the ILDS. The ILDS has actually been with us since the beginning as partners. We were founded at the World Congress of Dermatology in 2015, and they've been so supportive of the work that we're doing. We have in place an excellent partnership, and quite honestly, they have been instrumental in helping us to be here today, speaking to you, and helping to introduce us to the WHO and how we can be working as patient organizations within this very complex environment. And also a big thank you to the WHO's NTD department. We have had quite a number of meetings over the past almost year with the department, and we are working to find ways to collaborate and to support the work that they are doing, and we're just grateful to have been able to be here and to be part of these important discussions. And finally, just thank you to all of you in the room for all of the incredible work that you are doing on behalf of patients and communities all around the world. Thank you.
Merci beaucoup.
Thank you very much, Jennifer Austin. I'd now like to introduce the next speaker, who will be telling us about depression and quality of life amongst persons affected by filarial lymphedema. Please go ahead.
Thank you for the introduction, and good morning, everyone. I'm Carrie Barrett. I'm a PhD student at the Liverpool School of Tropical Medicine, based in the UK. And next, please. And today I'm going to be talking about a study in Malawi where I looked at the prevalence of depression and quality of life amongst people affected by filarial lymphedema. So I identified risk factors and also investigated the impact of an enhanced self-care intervention. Next, please. So lymphedema is a disabling and disfiguring condition caused by lymphatic filariasis, or otherwise known as LF. And as for all the skin NTDs, these conditions can impair individuals' well-being, whether that's through the physical symptoms, maybe pain, discomfort, or itching, or due to the severity of the disease itself. And also stigma can attribute to individuals suffering from mental distress as well. Now, not only are people with lymphedema subject to physical disability and impaired well-being, but they're also prone to experiencing acute attacks. And these are painful fever-like episodes which can occur when secondary infection enter the damaged lymphatic system. And they can last up to 2 weeks, and they can result in loss of earnings and days off work as well. So I just want to introduce Malawi. You can see on the map there. And this is a country where LF is endemic. Now, the national LF program has managed to successfully achieve mass drug administration across all endemic areas. So now it's shifted its focus onto providing morbidity management for affected persons. So for people with lymphedema, this means training them in an enhanced self-care in order for them to manage their symptoms. There's been no previous research on mental well-being in people with lymphedema or LF in Malawi. And as this is the same for many countries and programs, but Malawi is currently not providing any mental health support into program activities. Next, please. So the objectives of my research were first to determine the prevalence of depression and low quality of life in people affected by lymphedema, and then to identify socio-demographic and clinical risk factors associated with depression and low quality of life. And finally, I wanted to measure the impact of this enhanced self-care intervention on depression and quality of life over a 6-month study time period. So a prospective cohort study design was used with a total of 311 patients. So 150 were taken from the northern district called Karonga, and then 150 were taken from the Chikwawa and the Sandy district in the south. And these are hotspot areas where lymphatic filariasis is highly prevalent. Next, please. So baseline surveys were conducted with participants, and then following this, they were trained in enhanced self-care protocols. So this was developed by Dan Douglas, and these include the current recommended WHO lymphedema management activities. So next, please. You can see in the video, this is daily hygiene exercises, so washing of the limb with soap and water, and also skin and wound care, so applying antifungal cream to affected areas, and also elevation as well, and wearing comfortable footwear. And then in addition to these standard WHO activities as well, these enhanced self-care activities, which included this deep diaphragm breathing, which was to encourage fluid like blood and lymph to move towards the heart. and done in conjunction with a lying down exercise. This was really to increase lymph flow and also trying to recover the lymphatic system functioning as well. And in addition to this, there was also skin mobilization, which was to gradually soften fibrous tissue, which can be quite difficult to reverse in the more later stages of lymphedema. And then you just saw in the video there the lymphatic massage, and this is done after the deep breathing, and this is done in the direction of the fluid movement to move fluid towards the lymph nodes in the groin. And then in addition to this, walking, drinking water and eating fresh fruit and vegetables, as good nutrition is essential for wound healing as well. So after the individuals were trained in this enhanced self-care, following this, a 3- and 6-month post-intervention survey was conducted. Next, please. So embedded within the surveys were 2 questionnaires. One was to measure depression using a patient health questionnaire or a PHQ-9 tool. And this asked individuals to reflect on topics in the last 2 weeks, such as moods and sleep, all the way up to suicidal thoughts. And answers were collected using a Likert scoring system. Scores ranged from 0 to 27. And then similarly for quality of life, an adapted LF-specific quality of life questionnaire was used, each with 3 questions on 7 different domains, including pain, mobility, and also psychological health. And scores range from 0 to 100 here. And you can see at the bottom, these are the clinically defined cutoff values, which were used to calculate the prevalence for depression and quality of life as well. Next, please. So to identify risk factors associated with depression and quality of life, sociodemographic risk factors I looked at included age and gender and also geographical location as well. And also I looked at lymphedema care history, so whether the individual required a carer or not. And then clinical risk factors I looked at lymphedema staging. So for this, I grouped individuals into mild or moderate to severe category. And also I looked at the number of acute attacks, so these secondary infections causing fevers that an individual would experience in the last month or 6 months. And also embedded within the survey was an open-ended question, which was tell me about your mental health. Next, please. So for my analysis, risk factors were identified using beta regression analysis, so screened for p-values of less than 0.05. And then to assess changes in, to assess the impact of this intervention, I looked at changes in scores over time using data visualization and Wilcoxon tests. And also, I did some more complex beta regression models as well, which included secular time, so time as the study went on, and also time since that individual had started the intervention in the absence of a control group, just to see if the relationship between these and if individuals' scores were just changing as a population phenomena, or if it was down to the intervention itself. Next, please. So my results then for the prevalence, I found depression in 23% of study participants and quality of life in 32% of study participants. Next, please. And I found that individuals that were experiencing a higher number of these acute attacks were significantly associated with higher levels of depression and lower quality of life. And this was also the same for people with caregivers as well. I found that females and the more moderate to severe staging was significantly associated with lower quality of life in comparison to the men and mild staging. And also, individuals from the southern districts were also associated with higher levels of depression as well. Next, please. So to address my third objective, which was to measure the impact of the enhanced self-care intervention on depression and quality of life over the study time period, firstly, I visualized the data. Next, please. So you can see here from the diagram, this represents individual depression scores at baseline, 3-month and 6-month, using these clinically defined cutoff values. So you can see the green represents no depression, and each square is an individual depression score. They stay the same place over the 3 grids. You can see here that depression does actually fluctuate over the study, but the general trend is that less people are depressed at the 6-month follow-up. But there still are some individuals above the threshold. So I just took some quotes from these individuals, but I would also like to point out that each square here is a score, and it represents a person, each with their lived experience and different challenges they may face in their lives. So I think these quotes do represent this nicely. Next, please. So one was a female who said she had an acute attack a few days back and couldn't take care of her baby. Another male said he was stressed because his leg makes it hard for him to do other things like business. And then a female said she felt like a burden to her children. Next. And then similarly for quality of life, you can see that there is some fluctuation in quality of life scores over the study time period, but there's a more dramatic improvement in quality of life. And at the 6-month, only 2 individuals are above the threshold for moderately low quality of life. And again, I just looked more in detail into these individuals, and one was a male who said he needed someone to help him wash his limb, but reported no carer to help him. And then a female described sickness as the main barrier for her conducting her lymphedema self-care. And then I took a quote from a male who said he's always frustrated at 3 months, but then at the 6 months, he said he's no longer worried since the acute attacks have stopped. Next, please. So to look at the impacts of the intervention using statistical analysis, on the left you have a graph of each dot representing depression scores at baseline, 3-month and 6-month, and again on the right for quality of life. So you can see both of them are declining or decreasing through the different time points. And there was a statistically significant difference found with depression and quality of life at baseline in comparison to the 3 and 6 month. However, when I did some more complex modelling, I did find that, the modelling included secular time, so time as the study went on, and also the time since the intervention had started for that participant. And I found that individuals with these higher depression scores and lower quality of life scores did see the greatest improvements. However, this decline couldn't be directly attributed to the intervention itself. However, for quality of life, we did find that generally people's quality of life did just improve over the study time period, unrelated to the intervention itself, and this is perhaps something that we didn't measure. Next, please. So I think this study really highlights the wider burden of LF, finding depression in just under 1/4 of study participants and low quality of life in just under 1/3. However, I don't think this captures individuals experiencing other forms of mental distress, for example, anxiety. And I also think there are limitations to using a tool such as the PHQ-9 in a context like Malawi, just because of its cultural interpretability, which is something that I'm actually looking into validating this tool within this context. But I also think this is a wider challenge in this field as well for using valid tools and developing tools within these contexts. I think it's evident that these people that are experiencing acute attacks do require more care because of this association with depression, but also in other research that found increased number of days off work and also associated a major contributing factor to LF-related disability as well. I think that the enhanced self-care intervention may play a role in reducing depression and it's shown to improve lymphedema status and improve acute attacks. However, I think really that sustained morbidity management for individuals with the addition of psychosocial support should be recommended for programs, whether that's through counselling or peer support groups as well. And finally, I just wanted to touch on some qualitative work I'm conducting with a subset of individuals from this study, where I've been interviewing them and exploring their experiences of mental well-being, and also trying to understand any barriers for them implementing this enhanced self-care intervention for the affected people, but also at the program level as well. Next, please. So I just wanted to thank the LF programme. Without them, this work wouldn't be possible, and also my very supportive supervisors as well. Thank you.
Merci.
And thank you very much for this excellent presentation. You've really given us an overview of the mental health of the patients, and it's an extremely important subject. I'd like to remind all the people who are following online that they can ask their questions in the chat, and we will refer to your questions during the discussion part. The next presentation will be online, and I'd now like to give the floor to Hannah Berrien, who will be talking about informal health provider roles in addressing stigma and mental health needs among people affected by skin NTDs in Iberia.
I am a research fellow with the Redress Liberia project. I will present on informal health provider roles in addressing stigma and mental health needs among people affected by skin NTDs in Liberia. At Redress, we use a person-centered approach to evaluate, develop, and adapt health systems interventions for the management of skin NTDs. We want to investigate the role of informal health providers in the management of people affected by skin NTDs in Liberia. We want to understand the experiences and
Unfortunately, the sound quality is unfit for interpretation purposes.
NTDs. We will co-design an intervention to improve engagement of informal health providers through the use of participatory approaches. Redress use participatory action research, developing solutions together. During our formative phase research, we use series of participatory research methods, including photo, voice, and vignettes with the traditional and the faith healers. We disseminated our research findings at the county level. We also developed tools for the informal health provider, and we did sense checking of the tools. We conducted training for 588 informal health providers, and the training emphasized on recognizing skin NTDs, referring patients to the health facility, providing basic psychosocial support, using a look, listen, and link guard, and understanding stigma. We use participatory methods for our formative phase research, which include key informant interview with 5 participants, photo voice with 16 participants, vignette with 16 participants. After our intervention rollout, which is our post-training, we conducted a focus group discussion with 4 traditional and faith healers, along with the facilitators of the training. And we are conducting a reflective diary with traditional and faith healers, 4 of them. Our results on perceptions about people affected in skin NTDs before training. Informal health providers had empathy towards people affected by skin conditions, as well as those experiencing mental distress. They also reported stigma as a reason for people affected to conceal conditions, and they need different approaches to address stigma. And they also place emphasis on trying to dispel myth that underlying stigma related to specific health conditions at the community level. They providing talk therapy and counseling as part of their role. They also identify, referring, encouraging patients to seek care at the health facility and they desire to collaborate more with the formal health system. Informal health provider roles and responsibility include physical support, for example, cleaning a wound of a person affected with NTDs, spiritual support where faith healers provide prayer, and mental health support include providing counseling to patients and encouraging family support of people with mental health conditions to avoid relapse. Social support, for example, the provision of soap and shelter to affected persons. Additionally, our findings from our formative phase highlighted the key role that informal health providers, including traditional and faith healers, play in providing care for people affected by skin NTDs, as highlighted by this photograph from a photo voice participant. And the quote also demonstrates that patients often turn to informal health providers either before or after seeking biomedical care, which may not have addressed their needs or provide cure for their condition. Our formative phase research also revealed a gap in the availability of mental health service provision by community health workers. And because of the gap, many people experiencing mental illness seek care from informal health providers. And the informal health providers, such as traditional and faith healers, try to address this gap using different measures, including trauma healing class, as described by a photo voice participant. Our intervention update. We have conducted training across our 3 intervention counties with 588 informal health providers, faith and traditional healers. And our training covered early referral of patients, the recognition of skin NTDs, being able to dispel myth in the community, and providing basic psychosocial support using the look, listen, and link method, and understanding stigma. All of the trainings, they were observed by the research team. We also conducted our midterm review meeting with informal health providers and other stakeholders like health workers and the Ministry of Health. So at the midterm review meeting, we discussed challenges, and also we find avenues for improvement as we go along conducting our research. Results on changes in beliefs and practices after training. Need to seek medical advice before starting to pray or work on a patient was emphasized by faith healers, and many faith healers expressed the desire to comfort and support people affected, and also faith and traditional healers expressed the need to avoid stigmatizing people and maintaining their confidentiality, and they plan to share advice about how to prevent NTDs, and also encouraging the community to clean their surroundings. And they also plan to raise awareness in the community about skin condition. And they describe their intention that they will be able to refer more patients with skin condition. And also the desire for more collaboration was expressed by them as compared with before training. For challenges, some participants, they describe mixed experiences with health worker attitude to patients. Uh, and the health workers can get upset with faith and traditional healers if they keep the patient for a longer time before referring them. And some of the traditional healers felt that they have no relationship with community health assistants, community health volunteers. They are not familiar with them. And other faith healers refuse also to refer patients due to their perceived spiritual responsibility to care for patients. and the informal health providers survive based on income they earn from treating patients. And because of this, it creates challenges to refer patients, and they use this as a means of survival for them. As a key take-home message, traditional and faith healers play a key role in providing support and addressing stigma. Traditional and faith healers, they are willing to collaborate with the formal health providers. From our findings, this is a quote that demonstrates that the formal health providers sometimes flee from affected persons when the soul is smelling bad, but the traditional healers who go closer to them and provide treatment for them. So no matter what, traditional practices, traditional healers, they are important when it comes to providing care for people affected by NTDs. Combating NTDs require multi-sectoral collaboration between the formal and the informal health system. This is a link to a redress intervention manual. We want to say thank you to the informal providers for taking part in our study. We also want to say thanks to our funder, the National Institute of Health, for funding our redress. And we want to say thank you to our collaborating and affiliated partners for the level of collaboration within redress. Thank you so much for listening. Any questions or comments?
Oui. Vous avez dû constater que
I think that everybody noticed that interpreting was an issue because we requested the presenter to speak directly online, but unfortunately the speaker recorded the presentation. So please understand that there are caregivers that are working at an informal level in all our countries. And they provide care in a spiritual way, social way, physical, of course. And our presenter was trying to introduce us to this and inform us. And it's a shame that we couldn't hear the interpretation. It's an important aspect that exists in all our countries. Now we are going to invite the last presenter, who is going to talk to us about Ethiopia. And we have our colleague who's going to present impact of social intervention. I had it open and I don't know where it is. No, it's fine. It's here. It's here. Why?
The UK NHR funded 5S Foundation. I will be talking about our research entitled The Impact of Social Intervention on Poroconesis-Related Stigma in Northwestern Ethiopia. Poroconesis is one of the skin NTDs that results in the swelling of lower legs among affected individuals. It's caused by the interaction of genetic, environmental, and behavioral factors, but it can easily be prevented if susceptible individuals wear shoes on a regular basis. Around the world, 4 million people are affected, and Ethiopia bears the highest burden of the disease with 1.6 million patients. Poroconesis imposes several economic and social challenges on affected individuals as well as their family members. We consider poroconesis to be a social disease, as it's not an equal opportunity disease. Exposure to the condition as well as access to treatment are highly influenced by individuals' social position. In Ethiopia, a number of interventions have been implemented to increase access to treatment, enhance people's understanding, encourage preventive measures, and reduce public stigma. However, we know little about the impact. To date, evaluation studies in developing countries have mainly focused on the implementation, with little focus on the impact of the context, which may promote or restrain interventions. To fill this knowledge gap, we conducted an evaluation study on the effectiveness of isomifended next steps for poroconesis patients in Amhara region intervention in reducing the impact of poroconesis in Ethiopia. We selected the context and implementation of complex intervention, also known as the CC, as our evaluation framework. This evaluation will provide an important input to much needed but currently non-existent social intervention to end the suffering of people affected by poroconesis and potentially other stigmatized skin NTDs. Next slide, please. We employed a mixed method intervention design. We purposefully selected 2 districts in northwestern Ethiopia. We conducted a desk review to examine health programs related to NTDs and poroconesis and the project documents. We then conducted in-depth interviews with patients, for focus group discussions with community representatives, key informant interviews, and observation at intervention delivery points. This was followed by a confirmatory survey we conducted with 369 rural households, 42 of whom were affected by poroconesis. Finally, we conducted observation and key informant interviews at implementing organizations. Next slide, please. In line with the CC framework, we found contextual factors that have affected the intervention. Ethiopia has shown commitment to control poroconesis by rolling out national programs and guidelines. This has created an enabling platform from which to implement the project activities. The 2 districts we have selected are among the areas that are highly affected by poroconesis, and this has encouraged community's participation in the project activities. Gender appears to be an important influencer of health, as husbands mostly make treatment-seeking related decisions. Non-scientific beliefs, such as contagion and heredity beliefs, were ubiquitous and were correlated with stigmatizing attitudes. About 87% of unaffected individuals were not willing to marry patients. Patients face frequent acute attacks characterized by inflammation, fever, and chills, and they tend to stay in home and in their neighborhood due to mobility problems. The condition also affected female patients' gender and sex role. The mother of a patient said she could not take care of her child properly due to frequent pain. Sometimes she can't breastfeed her baby for 2 consecutive days. So as you can see, this can have an implication for decisions related to marriage and childbearing. Next slide, please. Next, implementation. The implementers utilize government healthcare centers in a bid to mainstream poroconesis services into local healthcare structures. The intervention provided trainings for health professionals and the public and distributed supplies to affected individuals over a 3-month period. The intervention reached 63% of affected people, and 88% of this reported continuing to implement the intervention as learned. Worryingly, females' participation in the intervention was low. Only 23% of the participants were females. About 80% of unaffected committee members had engaged in health education interventions, and nearly all reported that they fully comprehended the message from the intervention. Involvement in the intervention resulted in improved shoe-wearing practice and holding fewer stigmatizing attitudes against patients. Next, please. Now let's move to the organizational environment of the setting. The intervention was implemented by 2 NGOs known as IOCC and NAPAN. Each performed different tasks. Both organizations had clear organizational rules, mission, and vision. We further found that the staff are fully committed and have good reputation in implementing similar interventions. However, shortage of overseas funding has affected the NGO's capacity, as there is little interest from international donors to fund diseases that are not amenable to mass drug administration. A staff of an NGO noted, funders are less motivated to fund non-life-threatening and drugless diseases that are not amenable to advertised manufactured drugs. Next slides, please. Success and challenges. The project managed to reach affected individuals who had never had access to health services before. The project succeeded in convincing people poroconosis is indeed a preventable and treatable disease. It also improved staff capacity to provide treatments for patients, and it reduced public stigma. However, due to lack of follow-up from health professional side, a number of patients have defaulted from the project activities. The project further lacked psychosocial support and empowerment activities that might have been very important in reducing enacted and felt stigma. The project only covered a small part of the unaffected population, and few patients received supplies and footwear. Next, please. We'd like to recommend the following. Implementers should include home-based interventions for affected individuals with mobility problems. They also need to provide psychosocial support and design economic empowerment activities to reduce stigma. Health education campaigns should be conducted in an institutional setting in traditional institutions in order to expand accurate understanding about the condition and discard misconceptions. As I've said earlier, the NGOs are struggling with shortage of funds. So NGOs as well as governments in developing countries should present poroconosis and similar entities as global health phenomena. Fighting these conditions means fighting global inequality, poverty, and migration. Thus, the NGOs should equal this. Moreover, they shall consider domestic funding to strengthen themselves in a sustainable manner. Next, please. Take-home message. Health interventions can be influenced by social and structural factors that are intertwined with one another and can alter the effectiveness of the intervention. We have seen that interventions cannot be wholly understood by simply studying what happens at delivery points. Developing an optimal person-centered intervention should take note of social and structural factors, their interactions, and tensions arising from these interactions. For instance, involvement in the intervention was affected by gender inequality. So understanding these critical factors will better equip interventions to challenge the structure and institutions that create and sustain risks. Next, please. Charles Darwin wrote in Voyage of the Beagle, after witnessing the inhuman consequence of slavery in Brazil, if the misery of our poor be caused not by the laws of nature, but by our institutions, great is our sin. Thus, if we can design and implement interventions that fight institutions and structures that cause ill health, we can make this world a little healthier. Next slide, please. I would like to thank the study participants for their stories and time, local officials, intervention implementers, and funders. I would like to thank and acknowledge NIHR that funded our study. Thank you so much. I can answer any question you may have about our study.
Thank you. Thank you very much for your intervention. And the series of presentation makes me say that porokerniasis is a disease that is very present, and you have talked about social support, care, and how that has brought positive influence and decreased stigma. You've also talked about the challenges that are related to care and, of course, all the coverage and interventions that have been made. Now we are going to open the floor to questions. And I would like to talk about an online intervention or an online question for Mrs. Carey. Dr. Sin wanted to know about lymphatic massage. You talked about it in your video, and Dr. Sin would like to know if these massages are recommended. Dr. Carey, the floor is yours.
Thank you. Can you hear me? Thank you for the question. So currently it's not recommended by the WHO in policy. However, there is evidence to suggest that there are clinical improvements to lymphedema status and reductions in acute attacks from using this lymphatic massage. So I would recommend this technique to be used. So the lymphatic massage is to be done after the deep breathing exercise. So the deep breathing exercise is to encourage lymph flow, and then really the lymphatic massage actually is very gentle just on the surface of the skin, because of the lymph vessels are very close to the skin. They don't have to be done too harshly, and they will gently encourage fluid to move up into the groin, and it is showed to reduce, to improve fluid uptake, such as in the groin. So, yeah.
Merci beaucoup.
Thank you very much.
Please, do you want to say something? Yeah. Voilà, j'ai vu.
I saw a hand up this way. Please, you have the floor.
King, I'm focal point for the global program to eliminate lymphatic filariasis
Microphone, please.
Here at WHO. Can you hear me now?
Yes.
Just raise your voice.
Okay, so, yep, thanks for the question. And
Il faut utiliser. Est-ce que vous pouvez utiliser le voilà? Oui. Pour écouter.
Test.
Okay.
This one is better? Good. So WHO will be putting through a new lymphedema management guideline, going through the WHO guideline process for several interventions. And this lymphatic massage and deep belly breathing will be included for a full evidence review. At the moment, we haven't had that, so we don't recommend these techniques, but we are going to consider that in the upcoming guideline. Thank you.
Merci.
Thank you very much. Thank you for clarifying that regarding lymphatic massage. You have the floor.
My question is for Wim. Right at the beginning of your presentation, you presented us with a challenge, which was the woeful inadequacy of global data on the true human cost of skin NTDs. that goes beyond incidence and prevalence. And I'm just wondering, is there a way of fixing this? How do we improve it? Or should we?
Well, I think to start with the last question, I think the answer is probably yes, because policymakers and funders require data. I think we can say that some of the impact has already been established in this meeting. So if you didn't need additional resources, for example, and if you didn't need the political commitment from decision makers, then you could say we could just get on with doing the things that we know work, which have been quite well established. But I do think that we need the data. We need data, especially at the population level, and we do have data from several smaller studies that establish this effect, but we don't know at the population level the numbers that we talk about. I'll talk a little later about a study in India where we did try and enumerate all people with lymphatic filariasis and leprosy-related disability in 2 districts. But those kind of data are needed. We don't necessarily need to do that everywhere. I think we can, through modeling, can perhaps extrapolate that and get to burden estimates that are reliable enough to work with.
I would like to mention the study that I spoke about in my presentation, which is called Global Research on the Impact of Dermatological Diseases. The word impact, I think, is key. In this patient organization-led research project, we're working with University of Hamburg and Cardiff University, and we have actually created a new patient-reported outcomes measure that measures the impact of disease from the patient perspective. This has been developed using the best practice Cosman criteria, and we believe will stand alongside or eventually replace the DLQI. And the reason that it's best practice is that patients were involved in the creation of the measure, and we have created that measure exactly for the reason that we're discussing right now, which is that there isn't enough data to explain the burden of disease from the patient perspective. We know that policymakers want to hear from patients, but they need it in the form of data. So this will provide that. We will be the first users of this measure, which is being translated from English into 16 languages. And we will launch our global research study in June. It'll go from June until September, and we want as many patients around the world as possible to respond so that we have data sets that we can then provide back to countries and organizations to be able to advocate on behalf of these patients on an evidence base.
If I can just add one point that relates to this and to what Rod was asking, and that is that we shouldn't forget human rights, and we shouldn't forget that people actually have the right to health, and therefore the right to health services. And so you could say one additional reason for needing data is not so much should we do intervention or not, because they have a right to these interventions, but we need to distinguish interventions that are effective from those who are not. And I think that is also a main reason why we need data.
Well, thank
Merci,
you.
merci, oui.
Thank you very much, please.
The Brazilian Ministry of Health. To introduce topic, I'd like to make a question to Dr. Van Brakel. For tuberculosis, we have been widely using the concept of catastrophic costs that is defined by the costs related to TB management exceeding 20% of the annual pre-TB household income. Do you believe that this is a useful concept for our neglected skin disease? Because seeing your presentation, I could notice that the minimal indirect cost that the families and patients had was 20%. So could you comment on that, please?
Answer can be short. Yes, I do.
Thank you.
Microphone, please. Mr. Nicola Holmes, please. You have the floor.
On a reçu une question ici. Oui, Monsieur
Mr. Nicola Holmes, please. Nicola Homer, excuse me.
I am Nicolas Homer, MD, advisor for the beautiful Belle company and VP of primary care in France. Dermatology and psychiatry are two specialties which are very good medical fields as radiology for new technologies, and especially AI. The presentation of our colleague, Dr. Brackel, Carrie, and Anna, and make me think about ICOP Monitor, WHO application very successful for fragility, which screen six medical fields, included psychological. So my question is, Carrie, Wim, and all, Anna, what do you think about digital therapeutics, which could mix derm NTD and psychological intervention for health workers everywhere in the world, and of course self-care intervention?
Voilà, voilà, Wim.
Wim, maybe you would like to answer the question?
Yes, thank you very much for this question. I must confess that I personally don't have any experience using digital interventions, but I know that during the COVID pandemic, there were quite wide pilots and interventions that were run using digital means, whereas we would have previously said, well, for something like counseling, you have to have a face-to-face interaction. And it was surprising to see how well that worked under the circumstances. I would still say that probably for those type of interventions, personal contact is optimal, and that can often be achieved by involving peers, so people who are local to where the people live. But certainly in following the example of teledermatology, if more expert help is needed and it's not locally available, then we should look at possible digital solutions.
J'ai vu Monsieur Amari.
Mr. Amari?
Oui, merci.
Thank you, Abba Amari from the Assad Foundation. I have a question for Dr. Wim and also for Jennifer on, well, my concern is about the psychosocial assistance for the impact on people affected by skin NTDs needs to be fitted to their needs. My concern is there a double risk if we organize them into associations? Can that lead to an increase in the stigma that they suffer? Thank you. So the question is for Wim and for Jennifer. Does the organization of patients into associations increase maybe the risk of stigma? Thank you.
Thank you for the question. That's an interesting one. I think that patient organizations can be key in helping to dispel and to decrease stigma because they can provide information and education to those who don't understand the disease. And they can also help build capacity and ability among patients to be able to advocate for themselves, to educate others, because they may feel quite overwhelmed by the fact that they are living with this condition and not know how to explain it to others. So patient organizations can be very helpful in providing them with that type of support. So our experience with patient organizations is that being involved with those groups does reduce stigma and definitely increases their mental wellness. Thank you.
Yes, thank you for the question. And indeed, that is a very logical thought. We have faced that question in the field of leprosy, where organizing people who are quite stigmatized often into a group that thought, of course, came to the fore, and whether that would increase the stigma. But indeed, it's interesting to see that for stigma reduction, there are many factors that play a role. And one of those is the agency of the people themselves. And so if they actually are more empowered, have a better agency also to speak up for themselves, then that has a stigma reducing effect, despite the other considerations that may be there. What we do encourage is people to form, say, multi-condition groups. So, for example, with other skin entities, I gave that example of combination with LF. And so that there is some evidence, although not a lot of research, that does contribute to reducing stigma. But I think the added fact that once people learn to speak up for themselves and they improve their livelihoods, and that has a strong destigmatizing effect.
Oui, je crois que
I think that the assistance of this organization and their creation is a very significant matter, and to ensure that the organizations can be really effective and help achieve the goals. I have a question here too, I think. Let's go ahead.
Thank you very much. Mourad Moukni, from dermatologist from Tunisia. I have no question, but a small comment. I have to come back to massage in lymphangitis and elephantiasis. We know that in non-infectious lymphedema, the only efficient treatment is compression with bandage, and at least for pseudoconiosis, which is non-infectious, I think we should have more advocacy, and we should evaluate also the physiotherapy, the bandage, which is very costly, and we should, wearing shoes, that means the strategy and advocacy should not only for drugs, but for physiotherapy, bandage, which is the only efficient treatment. And I think we should evaluate also these devices and not only drugs. Thank you very much.
Merci beaucoup.
Thank you very much. Mr. Alisi? I'm going to come back on the question of the working with patients. There is less and less involvement of partners, and we find that they're not necessarily providing as much assistance, and people end up with major lesions and need more help. But I'd like to look more at the concerns of our colleague from Brazil, who wanted to think about this issue at a United Nations level. It's a right to healthcare. And if we look at it at a policy and legal level within the United Nations, we who work in healthcare are less and less heard. So it would be good to carry this further. Thank you very much. Mr. Ronald, please.
Thank you, Mr. Chair. I'm Ronaldo Schulte, Pan American Health Organization, WHO Office for the Americas. I have a comment. I would like to thank you, all the presenters, to remember us that mental health is a key component of MMDP. We always think about treatment, but we forget about mental health. So, thank you.
Merci beaucoup, monsieur.
Thank you very much, Mr. Gemma Ayla.
Monsieur Gemma Ayla.
I'm Gemma Ayala from Brighton and Sussex Medical School, and I have a question for all that speaks across all the presentations in this session. So we've seen quite a lot of qualitative research being presented today, and I was wondering if you could talk a bit more about the different or new kind of knowledge that this research methodology can provide, and also your thoughts on how we can better put that into evidence-based policymaking. Thank you.
Voilà, c'est une question pour...
That's a question to all of our speakers, so I'll let you choose who would like to answer.
Yeah, okay. So during my presentation, I have mentioned that so far evaluation studies have mainly focused on the implementation, focusing on its impact. We employed qualitative method. Of course, we also employed quantitative one as we did mixed methodology, but the qualitative phase was very important as it helped us to learn about the context in detail. We also studied people's suffering, people's perspective, relying on qualitative methods. So the qualitative methods were really helpful, as I've said, to learn about the context and to learn about people's experience and suffering with the disease, as well as their perspectives about the causes and preventive activities of against poroconesis. Yeah, so they are really helpful.
Merci beaucoup, la session.
Thank you very much. It's a very interesting session, but we will have to now move on to following our program. Now, I'm going to talk now about the concept of morbidity management and inclusion. It's very important to have a holistic approach to treatment, and that involves the management of morbidity, inclusion, social participation, fighting stigma, and ensuring mental health. So that is bringing all of this care to patients, and in particular looking at it from a point of view of human rights, and that's very important for us all. So now we'll continue with our agenda. First of all, we're all going to get up, and let's limber up a bit. So we're going to start with an exercise. All of our presenters were excellent. Let's applaud them. Let's applaud them in this way. Every time I roll my arms like this, you clap once. Keep clapping when I move my hands. Very good. Now we'll move a bit. Let's see.
On se dégourdit un peu.
Let's, wake ourselves up a bit. Thank you.
Bien, nous avons...
So, now we have limitations on our time, so we must continue with our session, and we're going to move next to a presentation on Tangiasis and ectoparasites. We have an online presentation from Mr. Beric Otieno, who is going to talk to us about the impact on neurocognitive functioning of Tangiasis, in particular in school-aged children. So we'll hear the presentation now.
Thank you for the introduction. Good morning, good afternoon, good evening. In the next few minutes, I am going to discuss the impact of Tangiasis on neurocognitive functioning, school attendance, and achievement among children in Uganda and Kenya. Next slide, please. We know that children, especially those in developing countries, are at risk of not achieving their full human potential And this is because of several risk factors that they are continuously exposed to, including inadequate parental stimulation, infections such as malaria and HIV, and other environmental like lead. Tungiasis, as it been introduced yesterday by Dr. Lynn Elson, is characterized by physical discomfort resulting from intense itching and pain, but also sleep disturbances. Next slide, please. This pathogenesis suggests that tungiasis contributes to poor neurocognitive functioning and academic achievement, but there is no implicating evidence to support them. Next slide. Next, please.
The interpreters apologise. The sound quality is insufficient for interpretation.
To achieve this, we investigated the impact of tungiasis on neurocognitive outcome in children in Kenya and Uganda. Next. And we conducted cross-sectional, community-based cross-sectional study in 3 phases, where we identified 454 children, of which 220 were infected with jiggers, and 234 were uninfected. We then used a broad array of neurocognitive tests, looking at language, domain, cognitive flexibility, nonverbal intelligence, working memory, literacy, numeracy, fine motor control, and response inhibition domains. Next, please. And just to take you through, the next slide, to take you through a bit of this test. For example, to test language ability, we used category fluency test. In this test, a participant is required to mention names of a specific category, for example, names of boys, and they are required to do this as fast as they can. And we realized that those with static class will just mention 2 names. However, those who are not affected would mention several names in the given time period. Next slide. And to test response inhibition, we use stroke test, where a participant is presented with a paper having colors spelled out. And then they are required to say the ink or say the color that is used to spell the word, but not reading the word. For example, in the first column, first row, we would expect a participant to mention red, but not purple. Next slide, please. And for cognitive flexibility, we used comprehensive trial marking test, where a participant is presented with a paper having markings, including the numbers and also the alphabetical letters. One is required to make, to join lines, starting from where it's indicated begin and move as fast as they could, joining the first number 1, the first alphabetical letter A, then to the number 2 and second alphabetical letter, number 3 to the third alphabetical letter, so on and so forth. And this is also timed. Next slide, please. So after getting the raw scores, we then use the specific test guidelines to transform this scores, factoring age and sex, but also school level of the participants, after which we conducted several tests that included t-test and analysis of covariance, and to test the potential risk factors associated with poor neurocognitive functioning. We used a multi-level generalized mixed linear effect NADA, adjusting for age, sex, schooling, parental schooling, and household socioeconomic factors. Next slide, please. And this slide just shows the characteristics of participants. where we found that our median age for the total participants was 11 years, ranging interquartile range of 9 to 12 years. We had more males, and also most of the participants were from lower grade, that is below grade 4. Next slide, please. We then compared the mean scores of various neurocognitive measures between the infected group. And this slide just shows a forest plot of difference in means between these two categories. And as you can see, we noted difference in means on all the 8 tests that we used. And all these differences were favoring an infected group. What this means is that those infected with tungiasis are performing poorer in all these domains. And interestingly, out of the 8 measures that we used, only one was not statistically significant, and that is cognitive flexibility. Next slide, please. In this table, we present multivariate analysis of factors associated with poor cognitive outcomes, and these are presented as beta coefficient with their respective 95% confidence intervals. What our results show is that tungiasis is associated with poor cognitive functioning in multiple domains. For example, we demonstrate that mild tungiasis on average is associated with 8.9 unit decrease compared to unit decrease in literacy scores compared to the uninfected. And similarly, the mild infection is associated with 1.7 unit decrease in language compared to the uninfected. For cognitive flexibility, we find 6.1 unit decrease, working memory 0.3 unit decrease. And similarly for severe infection compared to the uninfected, we find that those with severe infection, on average, they have 11 unit decrease in literacy scores, 0.7 unit decrease in fine motor control, 5.3 unit decrease in numeracy, and 2 unit decrease in response inhibition. Other factors associated with poor functioning also are residing in a specific geographical region, being male, school absenteeism, belonging to a household of larger size, and having a caregiver with poor mental health. Next slide, please. So just to introduce you to our second study, and this had been introduced yesterday by Dr. Lynn Elson. We nested a cross-sectional study to focus on absenteeism and academic achievement in our national prevalence, and this was done in 9 counties in Kenya. So this was done in primary schools, focusing on pupils aged between 8 and 14 years, and the study was conducted between October 2021 and September 2012. We randomly selected 95 schools where we selected 6 uninfected pupils and all infected pupils per school. And then we extracted data on school absenteeism and achievement from previous school term records. Next slide. Next. So in this slide, we are showing the results of a multivariate mixed effect model, again, adjusting for other known confounders, age, sex, again, and using random effect variable. And what these results show us that is that infected children have lose 1.5 days compared to uninfected children in the term. And this is adjusted for school type and other covariate like age and socioeconomic status. Next slide. And in this slide, I just want to go through some of the subjects that we looked at and we compared between the uninfected and infected. We looked at scores in maths, English, and science. And as you can see from the graphs, uninfected children were scoring better. And these scores are ranging from 0 to 4, with 4 being excellent scores. So what we saw is that uninfected children were more likely to have better scores above 3 compared to infected children, and this was across the 3 subjects. And when we ran multivariate analysis, adjusting for known confounders, we realized that those with Tungiasis have at least 5-fold lower odds of having higher scores in these subjects, again indicating that Tungiasis is associated with poor academic achievement. Next slide, please. So in conclusion, Tungiasis is associated with significantly lower scores in multiple cognitive domains, poor school attendance, and achievement. Our results show that Tungiasis impairs how children learn, interpret, and respond to stimuli, and this may impact their overall functioning. We therefore recommend integrated approaches aiming at early diagnosis and treatment to prevent the debilitating effects of this disease. Also, affected children should be provided with supportive care, such as counseling, academic support, and this is just to help them overcome the cognitive deficit, but also to achieve their full potential in school. And lastly, future research should investigate the mechanisms underlying poor outcomes and to the extent to which Tungiasis impact brain processes. Next slide. And with that, I want to thank the field teams and households in Kwale, Siaya counties, and Bujiri in Uganda, supervision team led by Professor Amina Abubakar, our funders, DFG, ISIPE, and all of you. Thank you.
Merci beaucoup.
Thank you very much. You were able to see that unfortunately it was difficult to have interpretation, but we'd really like to thank Mr. Otieno for this presentation, which looks at an ectoparasitosis which has a particular impact on some communities, in particular on indigenous peoples. Now we will continue our session, and I'd like to give the floor to Dr. Wim van Brakel, who is going to speak about stigma and mental well-being and social participation.
Women with disability due to leprosy and lymphatic filariasis in North India. Merci beaucoup, Dr. Wim.
Thank you so much.
Thank you, Dr. Christian. And we can skip this slide, I think. I would just like to say that I'm presenting also on behalf of Dr. Ashok Agarwal, Dr. Pradipta Nayak, Ms. Helene Broekamp, and Professor Mishra. And this study had 2 components. One was a formative component, which I will be presenting on, and also an intervention study, a proof of concept study of peer support using the new basic psychological support for NTDs tool. The aim of this study was that we wanted to be able to demonstrate what the benefit of having figures at the district level. So the study area was 2 districts in North India where we tried to enumerate all the leprosy affected, actually people with disability due to leprosy and people with disability due to lymphatic filariasis in those districts. And that was because we have as we discussed before, there are far too few figures available, and yet India accounts for some 40% and 60% of the global LF and leprosy burden, respectively. There have been major advances in the medical treatment, but not when it comes to psychosocial impact of the chronic implications and the disabilities. And very few studies are available at the population level that have looked at these aspects. So the research questions addressed in this presentation are: to what extent do women and men with LF or leprosy-related disability perceive and experience stigma? And to what extent are social participation and mental well-being affected? And is there a difference in the way and extent to which women and men are affected? The study was cross-sectional and used a mixed methods approach, and also the perspectives from the community and persons affected are both included. We geo-mapped all the persons with disability due to leprosy and LF, used a range of quantitative instruments, both to quantify severity of impairment, the lymphedema 3-grade severity score, the eyes, hand, foot score for leprosy. We used the SARI stigma scale to capture the experience of stigma on the side of persons affected, the Warwick-Edinburgh mental well-being scale, the PHQ-9 that we've heard now mentioned several times, the participation scale, short, simplified, and then 2 measures to look at stigma in the community, the EMIC community stigma scale and the social distance scale. The planned sample size was to include 200 of each of our 2 target groups, equally distributed in both districts and genders. We had a sample of community and family members, also equally distributed, and a community reference sample. The target was 60 in equal number of men and women, and we achieved a bit more than that. So just to quickly show you the overall numbers, this is about men and women with disability due to leprosy. We see that overall there were well over 1,000 persons with disability identified in those 2 districts, and there were more people with mild disability than with severe disability, and that didn't vary much across the 2 sexes. The same for lymphatic filariasis. Men and women, again, with disability due to lymphatic filariasis. Again, we see that there were many more with mild disability than with severe disability, but still, if you look at the overall totals, there were well over 10,000 people identified in these 2 districts with disability due to LF. And so still 1,600 of them who were classified as having severe disability. So our first question then is: to what extent do women and men with LF or leprosy-related disability perceive and experience stigma, and to what extent are social participation and mental well-being affected? The first instrument that we see the results of here is the SARI stigma scale, which looks at 4 domains of stigma: anticipated, internalized, and experienced stigma, and then also disclosure concerns. And what we see here, if we look at the top of this graph are the LF affected persons who experienced especially internalized stigma and had disclosure concerns, meaning that they were concerned, worried about others finding out about their condition. Their overall score on the SARI scale was around 6. Leprosy-affected people scored on all 4 domains of stigma and had a considerably higher overall stigma score. What is perhaps also worth noting is the fact that the LF-affected persons did not report any anticipated stigma or experienced stigma, while those with leprosy did. This slide is not moving forward very well. And I think so the overall score, as I mentioned, of those with leprosy was higher than with LF. And in this slide, we see the scores on mental well-being, and there we also have the reference scores from the community sample of nearly 100 persons, who by and large had either average mental well-being or high mental well-being, and while among our 2 target groups, it was especially low mental well-being, which scored close to 50% in both groups. Then when we look at depression, again, comparing that to the community members, we see the same pattern that the community members had either no depression or only mild and some moderate depression, while in the 2 target groups, quite a significant proportion had either moderate, moderately severe, or severe stigma, severe depression, I'm sorry. Then the participation restrictions, a similar pattern. The community members report either no restrictions or mild restrictions, and a very significant proportion of those with LF or leprosy-related disability had either moderate or severe participation restrictions, with no big differences between LF and leprosy. And then lastly, the question, is there a difference in the way and extent to which women and men are affected? So I put here all the outcomes that we looked at into one graph, with at the bottom also the community stigma, so that is measured from among the sample of people in the community. I think overall we see that there are differences between men and women, but only small differences. And the severity of disability is very similar in both groups. When it comes to mental well-being and participation, we do see differences with slightly higher percentages among men than among women, but those differences were not statistically significant. And with regard to lymphatic filariasis, a similar pattern, only the severity, the percentage of severe disability was lower, and also the level of experienced stigma was lower, which is interesting because, as you can see at the bottom, the community stigma scores were quite high. So there was the perception that there was stigma in the community expressed by community members was high, yet the persons with LF, they didn't experience a lot of that. So there was not a lot of discrimination around, you can say. And again, the other differences were not statistically significant. So I'd just like to acknowledge the district health authorities and the national programs of the Ministry of Health and Family Welfare in India, the Banaras Hindu University, the Institute of Psychiatry in Ranchi, Jharkhand, and the Indian Institute of Development and Management, and the Coalition for Operational Research in NTDs, who received funding through which we received funding from UK aid for this study. Thank you very much.
Merci beaucoup, Dr.
Thank you very much, Dr. Wim. This will be very useful for our discussions. Thank you for this presentation on stigma and the assessment of stigma and mental well-being amongst patients with leprosy and LF in North India. Let's move on to the next part of this session with an online presentation. Maya Simu will be giving a presentation on
intervention in reducing stigma related to lower limb lymphedema in northern Ethiopia. Merci.
Thank you.
Thank you very much. I hope you can all hear me okay, but please do let me know if you can't. So I've been asked to present on behalf of Dr. Abibayu Tora today. Unfortunately, he's having technical difficulties, so he hasn't been able to join to present. So I'm going to be presenting on his behalf. My name is Dr. Maya Zemrau. I'm based at the Brighton and Sussex Medical School in the UK. And I'm going to be talking to you about the role of a community conversation intervention in reducing stigma related to lower limb lymphedema in northern Ethiopia. Next slide, please. So as you all know, and as we've been hearing already, lymphedema related to skin NTDs imposes huge burdens on affected individuals and communities. And today I'm going to be talking particularly about lymphedema that's caused by lymphatic filariasis, podoconiosis, and leprosy. And that's kind of what we were looking at in our study. And we've already been hearing today about how stigma can act as a major psychosocial burden, and that can act as a major barrier to accessing morbidity management and disability prevention, or MMDP services. So the study that I'm going to be telling you about today is the community conversation intervention, which has been looked at and is believed to break the vicious cycle of psychosocial burdens of lymphedema through enhancing disease-related health literacy at the community level. So community conversation is an intervention that involves community engagement, and that has been applied in low literacy and resource-constrained settings to address health-related stigma. And what I'm going to be presenting to you today is the effect of community conversations in reducing stigma when added to a holistic care package, and I'm going to be presenting the quantitative results from our study today. We did also have a qualitative aspect to our study, but I'm going to be presenting the quantitative results today. And so this holistic care package that I just mentioned is actually the endpoint care package that we already heard about on Monday afternoon from my colleagues, Dr. Asrad Mengistu and Dr. Umar Ali. So this was a kind of comprehensive and holistic care package that involved physical health care, mental health care, and psychosocial health care as well, psychosocial interventions as well. Next slide, please. So the general objective of this study that I'm going to be presenting on is that we aim to quantitatively investigate whether community conversations, or CC for short, contributed significantly to stigma reduction when added into an integrated holistic care package, the endpoint care package, as I already just mentioned. And the specific objectives were to look at outcomes both at the patient level and the community level as well. So we were looking at whether the CC intervention, or community conversations, was associated with a reduction in both internalized and experienced stigma, or improvement of perceived social support amongst patients with lower limb lymphedema compared to controls. And we were also looking at community level outcomes to see, particularly looking at whether the CC intervention improved knowledge, attitudes, and practices in the community, again, compared to a control district. Next slide, please. So this was the study setting for this study, So as you can see on the smaller map highlighted in orange, you can see that's Awi Zone, which lies in the Amara region in northwestern Ethiopia. And that's where the study was set. And you can see highlighted in green on the larger map, the 3 districts in which this study was implemented. So 3 districts in Awi Zone in the Amara region in Ethiopia. Next slide, please. So as I said, this study was embedded within a larger study, which was the endpoint study you already heard about on Monday afternoon. And I think the slide might look slightly familiar because I think a similar slide was shown on Monday. So the endpoint study involved 3 different phases. Phase 1 involved the development of the holistic care package. Phase 2 involved a pilot study in 1 sub-district in the 3 districts that I just showed. And then phase 3 of the endpoint study involved scaling up the holistic care package to all 3 districts in Awi Zone. And then the study that I'm presenting to you today, the IMPRESS study, was embedded within that larger endpoint study and involved a quasi-experimental delayed intervention design that involved implementing community conversations and evaluating those community conversations as well. So the community conversations were implemented in 1 of the 3 districts in which the endpoint care package was implemented, and the other 2 districts were used as control districts. So in the 2 control districts, the endpoint holistic care package was still rolled out, but we added the community conversation intervention in the intervention district and then compared. Next slide, please. So this just shows the kind of processes that were involved in the implementation of the community conversation intervention that we implemented. So it involved a process of recruiting community conversation facilitators who were then trained and then deployed into the community. We then also recruited both affected and unaffected community members to participate in the community conversation intervention. And we then expected, or part of the intervention was that people who participated in the community conversation intervention to disseminate health messages about lymphedema in the community. And the CC facilitators were also provided with supportive supervision by health and district level staff who were also trained. Next slide, please. So in total, we recruited and trained 33 community conversation facilitators who, as I said, were also supported and supervised by health and district staff. In each CC session, we had between 30 and 50 participants taking part. And as I said, that included both affected and unaffected community members. Each participant participated in a maximum of 6 CC sessions over a 3-month period, and so up to a maximum of 2 CC sessions per month for each participant. And the focus on the community conversations was really on countering misconceptions about lymphedema using a range of different learning methods, including reflective, interactive, and participatory learning methods. And as I said, we asked participants to disseminate health information to the wider community after or throughout the duration of the community conversation intervention. Next slide, please. So these are the results that we found. So as I said, we looked at outcomes both at the community level and at the patient level as well. And see what you can see in the graph here is a comparison between baseline, so pre-implementation of the CC intervention, and follow-up. So this was a 6-month follow-up after the implementation of the CC intervention. And the intervention district is highlighted in blue, and the 2 control districts are highlighted in red. Just bearing in mind, as I said earlier, that the control district still involved the implementation of the larger endpoint care package, whereas the intervention district just involved adding the CC intervention to that larger care package. So what we found in terms of the community outcomes, so we looked at knowledge about lymphedema in the community, we looked at stigmatizing attitudes towards lymphedema in the community, and we also looked at social distance measured through the social distance scale. What we found that between baseline, so pre-intervention, and follow-up, so post-intervention, we found that all those outcomes improved over time, in both groups, both in the CC intervention district and in the control districts as well. So for knowledge about lymphedema in the community and social distance, we found that they both improved over time. So social distance reduced and knowledge increased. However, what was a bit surprising was that that was the case in the control district more so than in the CC district. So both those outcomes improved more in the control districts than the CC district. For stigmatizing attitudes, we found that, as expected perhaps, that stigmatizing attitudes reduced over time in both groups, but that was more the case in the CC group than the control districts. Next slide, please. These are the results for the patient outcomes. So for patients, we looked at discrimination measured through the DISC, internalized stigma measured through the ISRL, and social support measured through the Oslo 3 scale. Again, what we found for discrimination and internalized stigma is, and again, just to say perhaps that in the graph is presented in the same way. So you can look, so we have baseline and follow-up. Intervention districts are highlighted in blue and control districts are highlighted in red. So what we found that both discrimination and, so this was perceived discrimination by patients, and internalized stigma reduced over time, both in the CC district, so the intervention district, and the control districts. But what we found was that scores for both those outcomes, both for discrimination and internalized stigma, they were higher at baseline and endline in the control districts compared to the CC districts. We didn't find any significant difference at endline compared to baseline for social support, both in the CC and control side. So there was no statistically significant difference there for that outcome. Next slide, please. So yeah, I won't go on to detail, I think, in this slide. So this is just the models that we employed to essentially show what was just shown on the previous 2 slides. So I don't think I need to go into any more detail on that. Next slide, please. So to conclude, overall that we found strong evidence that the endpoint care package as a whole resulted in improved stigma outcomes, since all outcomes apart from social support improved over time, both in the CC and in the control districts. And as I said, we already heard more about that from my colleagues on Monday afternoon as well. However, when thinking about the community conversation intervention, there was mixed results, as I said. So that we did find that there was an improvement over time in stigma outcomes, both at the community level and the patient level, but that there was some mixed results, and that stigma outcomes didn't necessarily improve more in the community conversation districts compared to the control districts, and in some cases the reverse was actually true. So this kind of needs further exploration to find out exactly why that is. One explanation could be that the endpoint care package on its own was already effective in addressing stigma. So as I said, the endpoint care package was already a very comprehensive and holistic care package that involved physical health care, mental health care, and psychosocial aspects as well, which actually included some stigma reduction activities, such as health education messaging as well. So it might be that that on its own might have been sufficient and effective in addressing stigma, so that the CC intervention might not have added much or might not have added much value to this already very comprehensive and holistic care package. But as I said, this is something that needs further exploration. Next slide, please. So the key take-home message is that provision of comprehensive, holistic and integrated MMDP services may be adequate and appropriate to tackle stigma related to lower limb lymphedema, particularly related to lower limb lymphedema caused by podoconiosis, LF and leprosy in a resource-constrained setting like Ethiopia. Next slide, please. And this is just to acknowledge both the IMPRESS research teams and also the endpoint research teams, and particularly Abebaye Hutora, who unfortunately wasn't able to present himself today. Thank you very much. And also just to acknowledge our funder, Core NTD as well, who funded the IMPRESS project, and NIHR for funding the endpoint project. Thank you very much.
Merci. Merci.
Thank you. Thank you very much, Maya, for this presentation on the role of a community compensation intervention in reducing stigma related to lower limb and lymphedema in North Ethiopia. Last but not least, we'll be hearing from Professor Ahmed Fahal. But before that, I'm delighted to announce that he has received a reward, a certificate of appreciation from the NCI. So I think deserves a round of applause for that. And after this presentation, we'll be taking a photo with DNDi to celebrate this award that you've received for your fight against mycetoma. And you will specifically be talking about mycetoma, disabilities and stigma, innovative thinking, out-of-the-box solutions. Thank you, Professor.
Hello. Thank you very much, Stephanie, for offering you a seat to be very close and cozy to the presentation. Mr. Chair, ladies and gentlemen, it is a pleasure and honor to be here in the first ever WHO Skin NTD's global meeting. This is Sudan, this is Khartoum, and this is the junction between the White Nile and the Blue Nile. My name is Professor Fahal. I'm a professor of surgery at University of Khartoum, Mycetoma Research Center, the WHO Collaborating Center on Mycetoma. I'm going to talk about mycetoma, disabilities, and stigma, and to share with you some of our thinking out-of-the-box solution to these. I declare no conflict of interest in this presentation. All photos, images were taken after informed consent. The main objective of this presentation is to share with you experience on mycetoma, disabilities, and stigma, and to share with you some of the solutions invented by the Mycetoma Research Center, Sudan. And this is the outline of my presentation. I'm going to talk about mycetoma as a social, medical disease and a problem, and some of the intervention we did and to share with you some take-home messages. For those who may not be able to stay to the end of this presentation, I am going to conclude by saying that mycetoma is a scar in the human conscience, and our job is to heal it because it is non-glorious disease. Ladies and gentlemen, mycetoma, it is a chronic ladies and gentlemen, mycetoma, it is a chronic disabling disease characterized by massive deformities, destruction, and loss of function, and loss of life in some of patients that come late. You can see it can be very aggressive, as in this poor gentleman who had a blown-knee mycetoma, ended in above-knee amputation, recurrence in the stomach, and it had spread to the anterior abdominal wall, intra-abdominal cavity, and affected his urinary bladder. You can see how massive the mycetoma deformity can be, and you can see in this patient with actinomycetoma, amenable to medical treatment, how massive the disabling, figuring, mutilating disease. That should be a very clear treatment for this patient and outcome. Sadly, about 30% of our patients and you can imagine the misery of these young chaps with a patient, and this patient with a head and neck mycetoma. Mycetoma is associated with a lot of disabilities, difficulties, constraint, and amputation is an important cause of social stigma, poverty, and ignorance. For a female, it can put her at the end of the roads. No social life, a lot of difficulties in dealing with things. Mycetoma can be as massive as this, and the treatment can be as massive as this. And this is a total lower limb disarticulation for a mycetoma not responding to medical treatment. And here, even you can see the disease has spread to affect the intra-abdominal cavity and other structures. Mycetoma in endemic villages can run in families, as in these 4 members of the same family. All of them had mycetoma, ended in amputation. Mycetoma can be a big burden on family members. This chap has left his job overseas to come back to Sudan just to support this poor patient with amputation and mycetoma. And again, we have to remember that it affects the poorest of the poor in poor communities. These people, they use a self-made prosthesis, difficult to use, and it's hard to move around with this. Most of them, they had an old broken prosthesis like this. For this, the Mycetoma Center had come with some ideas and interventions to deal with these patients and their problems. One of them it is to establish 2 peripheral satellites for mycetoma patient care. We did a lot of field surveys. We appointed many community activists and social workers as ambassador for mycetoma. We established the Mycetoma Patients Friend Association to help this patient and to help themselves. Also, a lot of health education events and activities, and we engage ourselves with many fine artists in the country and overseas for advocacy of mycetoma. Furthermore, we work on the processes, the campaigns. As part of the holistic management of mycetoma patient, we had animal care construction, and we have a social media activities, and we have the mycetoma vocational and entrepreneurship center side community engagement activities, and that done in line with research. This is one of our satellites in one of the endemic villages where we see patients there, and we deal with them. The whole team of the mycetoma center moved to the village, spend few days there, and do the surgical intervention and other activities free of charge. In the villages, we do a lot of surveys using our TAPI. This is an application to collect data. And here you can see one of my colleagues doing ultrasound examination in one of the villages at midnight using a mobile torch. And this is one of our lab technologists dealing with a biological material. Again, you can see the torch of the mobile to have a light to do these things. A lot of problems, mechanical difficulties, roadblocks. These are the constraints we face during dealing with this patient in the field. In the field, we did more than 1,000 surgical operations and more than 1,500 ultrasound examinations free of charge for these patients. Again, that had led to reduce the number of patients coming with massive mycetoma. Most of them, they're coming now with a small lesion, and reduce the number of amputation among these patients. One of the solutions to deal with the problems of the mycetoma, stigma, and disability, we established sites.
Mycetoma is a neglected disease that affects parts of Sudan, especially rural areas where people live with a low economic level. When the treatment of mycetoma is delayed, a lot of patients become completely or partially incapacitated due to amputation of their limbs, which causes them economic and social problems and leads to the loss of their jobs. The Mycetoma Research Center provides treatment to patients, communicates with them, and organizes awareness and treatment convoys to their areas. The center found that there is a need to provide social and economic support to patients to help them after receiving treatment. Thus, we established the Mycetoma Vocational and Entrepreneurship Training Center, SIDE. SIDE Center provides training to acquire knowledge in the fields of sewing, carpentry, horticulture, leatherworks, pottery, foods, and others. To deal with
the mycetoma amputation, we are now collaborating with one of the incubator in Khartoum, established by young pioneers to develop a new processes for these patients that can be easy to be used and light for them. And this is one of the patients with amputation of the hand and using these prosthesis, using his shoulder girdle muscles to move the fingers in these prosthesis. As these patients cannot come from the rural areas to Khartoum and big centers for the prosthesis to be done for them, we moved this mobile workshop to one of the villages where we did more than 160 artificial limbs for these patients and to complete their life journey. As we are dealing with this patient in a holistic approach, we managed to have these new animal cages for them to reduce the contact between the animals and the patients and the people and to reduce the number of patients. We established a state-of-the-art mycetoma media center, and this center is very much active in producing material for advocacy and awareness. We have now more than 120 video films, clips on mycetoma advocacy and awareness. We appointed many active member societies as mycetoma ambassador, and here you can see this is the top celebrity in the country, part of our group. They established what is known as We Are With You, and these are the 40 top celebrities, comedians in the country coming to the center, singing and talking to the patient. All these done under the research activities. We have a lot of research going on right now on the social impact of the mycetoma, economical impact on mycetoma, and we are now using artificial intelligence for more diagnosis accuracy for mycetoma. Mr. Chair, ladies and gentlemen, in conclusion, I have to say that mycetoma center in Khartoum is dealing with unique patients. We have unique diseases, and they have unique problems, and our job it is to find a unique solution for these patients. I am very grateful for our patients, the community, for helping us to helping them, and they are very grateful for what we are doing. And thank you very much for your kind attention.
Thank you very much, Professor Fahad. Thank you very much. Many moving images that show the distress that all these people have to go through. Now we are going to open the floor to questions and the discussion. I'll give the floor to my colleague.
I have a question for Dr. Wien van Brakel. In your study, there is clear that the disability and mental health disabilities, it's more in the leprosy group. Is it related to, in your opinion, is it related to the disease, or because in the group of leprosy there is more severe disabilities in the groups?
Thank you for the question. I think it may be true that, relatively speaking, the people in the leprosy disabled group had more severe disability, although the absolute numbers of people with severe LF-related lymphedema were higher in the two districts. But I think since there is a clear link with stigma, it is probably the fact that the stigma is more severe against persons affected by leprosy, and even the self-perception, as we saw, the internalized stigma, the anticipated stigma is more severe on the side of persons affected by leprosy. So I think that is probably a main reason for that. We have done also multivariate analysis, but I didn't have time to show that.
We have a question that was put to us online for Mr. Anabilian regarding the redress project.
Obligation to not refer patients to the formal health services, or is it more about money? Voilà. Anabilian, est-ce que...
Anabilian, are you here? Are you online? Could you take the question, please? Thank you. Thanks. You have the floor.
Thank you very much, Mr. Chair. My question is to Professor Fahal. First of all, thank you very much for the inspiring and fantastic presentation. Would love to have a copy of that. Yeah, and my question, although, I forgot to introduce myself. I'm Kazim. I'm the regional team lead for neglected tropical diseases for WHO's Western Pacific region. My question is more on the prevention side of mycetoma. As you mentioned that mycetoma is primarily a disease which affects people in hard-to-reach areas in Sudan and the most impoverished people. So given that context, if you can tell us a little bit more on the prevention, what other than the animal cages and having ambassadors and all these advocacy videos, what specifically you are doing within, keeping in mind the context of those people, who are extremely impoverished? Thank you.
Oui, Professor Fahal.
Professor Fahal, the floor is yours.
Thank you very much for this. Actually, it's a very difficult question because still we are not very sure on how the infection is taking place. There is a lot of gaps in the epidemiology of mycetoma. We know that traumatic inoculation of the causative organism into subcutaneous tissue may be the route of infection in this patient. And that is why made the prevention and control program very difficult. Right now, what we are doing early case detection and early case management to avoid patient coming late with very advanced disease and deformities and amputation. So that is why now we're having these satellite centers in peripheral areas where mycetoma is endemic. We have to go to the patient there, not let them come to us in the big centers, and to do the surveys, trying to find the patients at an early stage and to treat them. This is the main issue right now. Because if you wait for them to come to you, they will come late with very advanced disease, as we saw. So now in these centers, we are seeing them. We are trying to convince them to have the surgical intervention as early as possible, and all this done free of charge because they cannot pay for these things. So early detection and proper management and diagnosis are the important issue right now we are dealing with. We are still very far from having a very clear control, prevention, elimination, eradication plan for this patient. Thank you very much.
Merci beaucoup.
Thank you very much. Dr. Ronaldo, did you want the floor? Please.
Mr. Chair, seeing Dr. Van Brakkel's presentation, looks like there was some sort of a lack of a gender equality. And I'm wondering, and this question is for all of you, are you using some specific language or tactics to achieve gender equality? Thank you.
Thank you for the question. I am not sure how, from my presentation, you concluded that there was no gender equality, because there was equal inclusion of men and women in this study. And I think what we also showed was that we looked specifically for differences in experiences between these two genders. It is true that sometimes instruments may need to be adapted, or the approach may need to be adapted depending on the gender and sex of the respondent. What we have, for example, in this tool called the social distance scale is a verbal vignette which paints the picture of a typical case of either leprosy or lymphatic filariasis, and then that vignette is not only adapted to the condition, but is also adapted to the gender of the respondent. So that is one example of how that is done.
Thank you very much. I see another hand up here. Thank you. Go ahead.
Oui, merci, Monsieur le Président.
Thank you, Mr. Chair. I wanted to comment or add something to what Professor Fahal said. I am the focal point for mycetoma at the regional office at WHO, Afro. And I wanted to say that the issue with mycetoma is that it is an NTD that was added recently to the list of NTDs. And there's a serious issue in many countries regarding the mapping of this disease. Certain countries have declared that they don't have this disease while it is present. So it is an issue that we are currently working on for several purposes, for the mapping, in order to raise awareness, health staff and governments, in order to set up and implement a strategy at those three levels with the WHO. Thank you. Thank you. Indeed, we do need to implement a surveillance system in order to detect and get information and deal with this issue. We have a request that has come in online. In the room, is there a specialist?
President.
A specialist on rehabilitation? A specialist on snake venom, excuse me. Do we have a specialist in that field? Thank you.
Oui, voilà, c'est ça.
Réhabilitation ou envenimation?
Est-ce qu'il y a des interventions transversales qui sont...
Are there any cross-cutting implementations that have been done in terms of snake venom?
I'm not sure if she's here, but Professor Imke Stienstra was in the meeting, and she is working with the Liverpool Tropical Medicine on snake envenoming. But there was a BU meeting
Est-ce qu'il y a quelqu'un qui peut répondre à cette question parmi les...
Can anyone take this question? Thank you. Dr. Daniel, you wanted the floor?
Okay, thank you, Mr. Chairperson. Mine is a question to Professor Fahal. Thank you for your very interesting and enlightening presentation, as usual. So, and also your good work at the same time, I appreciate. I have a couple of questions. One is about the incidence of new cases of mycetoma. Because we don't see the trends, we don't have a good surveillance system globally and also regionally. How is the incidence now? I know the prevalence is increasing because of the number of chronic cases and the long duration of treatment, but do you see any change in the incidence over the past years, especially as interventions are intensifying to address the various known risk factors? Of course, there was a plan also to do a more comprehensive risk factor assessment. I don't know if that was completed. This is one question. So my second question is, there is this study going on also to improve the treatment duration and the treatment outcome. It could still be at a preliminary stage or advanced, but if you could also highlight us, give us some information as to the status of this study. Thank you.
Thank you very much, Daniel, for the important question about the incidence. Actually, the incidence is increasing because now we are going to the field, we are seeing patients in the field, we are doing active case detection and management of these patients. So definitely the incidence is increasing. The good thing that we are now seeing patients with a small lesion, amenable to treatment with a good outcome. This is the good news about what we are seeing in the field at this site. As you know, still there is no international, the number internationally is not well known for the incidence and the prevalence. Regarding the treatment, I have to say I'm very grateful for DNDi, Geneva, for supporting the first ever double-blind clinical trial on mycetoma treatment. The trial took about 5 years. It's finished now. Now we are in the stage of analysis of the data and writing up the paper on this. The good news that the new drug, it will be a very good drug because it will be taken once per week. Will be very handy and acceptable by the patients, and the compliance will be much better for what is available right now. Right now, what is available is itraconazole, 4 tablets per day, which is a very big hurdle on the patients and the family and the health authorities in endemic areas. The new drug will be taken once per week, and that is a big plus for the patients and the community, as well as the health service and the system, because it will be definitely more economical for both the patients and the health system as well. But it's very encouraging, and the results are very good, I think. Thank you very much.
We still have a time for a few other questions, please. You have the floor.
Bonjour.
Good afternoon. I'm Anthony Lixton from the International Alliance for Albinism. And I have a question regarding the session this morning. I heard about the impact of disease on patients. I heard about the importance of holistic approaches. We also discussed people-centered approaches and the importance of involving associations of patients. But we did not mention human rights. We are, of course, patients, but we are also human beings. And, of course, we aspire to optimal health in physical and mental terms, and also our human rights. So that means that we have the right to health, education, work, non-discrimination, etc. And our well-being and the quality of our life depends on all these rights. So I have a question regarding the importance of involving other parties in our work, in particular other UN agencies and organizations and experts in the field of human rights. Thank you. Thank you very much for bringing this up. In order to make the best of the time we have left, we are going to take a few questions and then respond to them. There's a question here, one on my right here, and one on my left.
Okay. Merci, Président.
Thank you, Mr. Chair. I am Dr. Ngissa Madi from the National Program to Combat Buruli Ulcer in Ivory Coast, and I have a question regarding mycetoma. I thank the speaker for his presentation. Now, what I would like to know is regarding the treatment of patients, mycetoma patients, treatment they are currently using, regarding the molecules and in the field before clinical trials yield results. is there a molecule that can help to mitigate the amputation rate among patients that suffer from this deep mycosis? Thank you. Thank you very much. Thank you, Professor Fahal, and thank you for the presentations. Yes, the photographs speak for themselves. And we thank all the health workers that are trying to care for these patients. But of course, public health always has to take a step back because, as you know, we don't have enough data. And we have, the most data we have is actually in Sudan. And in order to implement primary policies. So are you working with epidemiologists in your centers that who could provide a maximum of information regarding these patients and mycetoma? Thank you. I also saw a question on this side. Yes, please go ahead.
Thank you, President. I have also a question for Professor Fahal. I'm Professor Jean-Pierre Gagneux from Rennes University in France. And my question is regarding diagnosis, lab diagnosis. Of course, it's very important to distinguish mycetoma due to fungi and mycetoma due to actinobacteria. So how can we improve the diagnosis of this disease? Because this will drive the treatment. Thank you very much.
OK, donc nous pouvons...
Très bien. Sorry. Very well, Professor Fahal. We have 3 questions that were addressed to you, and the floor is yours.
Mr. Chair, regarding the treatment of mycetoma, as you know, we have 2 types of mycetoma. We have the fungal type and the bacterial type. The bacterial type is amenable to treatment by a combination of antibiotics. And the results are so good, but it takes quite a long time, and that is why you have to look for new antibiotics that can treat the patient in a very short duration compared with what's happening now. For the fungal type, it is a big problem because still there are very few antifungal drugs susceptible to be used for these patients. Currently, we are using itraconazole as a treatment of choice for 6 months, followed by sedate intervention, and another 6 months with antifungal, trying to reduce the incidence of recurrence and the other problems. Regarding the new molecules for the treatment of mycetoma patient, I am glad to say one of my PhD students in Tours University now, she is coming up with more molecules that can be used in the future as a drug for mycetoma patients. But right now, we are using this pre-purpose drug for mycetoma patients. The diagnosis of mycetoma, currently, it is a bit tedious. It is a long process, and it needs a lot of experience and equipment. The standard treatment, the standard diagnostic tool now, it is the molecular diagnosis for mycetoma patients. And I'm glad with our collaboration with Erasmus Medical Center now, we are coming up with more primers to be used for this diagnosis, for this organ to be diagnosed in the lab. We're having an ultrasound diagnosis, cytology, but still looking for patients for more collaboration for having a point-of-care test. Currently, we are working with 4 universities in Japan and Netherlands to come up with a point-of-care test for mycetoma patients so we can be able to diagnose the mycetoma patient at the level of the field. Thank you very much.
Merci beaucoup.
Thank you very much. This is a very interesting discussion, but the session has reached its end. And I think that all the presenters deserve a round of applause. And now, as I announced, I would like to invite the DNDi team to come and join me along with Professor Fahal. Please please come here. Please come to the middle of the room. I'd also like the participants to come closer so that we can take a photo with Professor Fahal. Please.
Venez. Voilà.
Everybody come.
Oui, please.
Please, everybody come. Yeah, come. Just come and stand in the background. Yeah.
Oui, je crois que ça marche, non? C'est bon? Ça marche? Hein? Non, ça marche ou pas? Non, ça marche pas. Oui, ça marche. Ça marche là? OK. Yeah. Let's not cry, huh? Okay? You mustn't cry. So I'd like, this is a very important moment for mycetoma. For us, with many of you, we managed to add mycetoma to the WHO NTD list. This was in 2016. It was a very important moment for some of us. Look at Professor Fahal. And 7 years after, we are here to celebrate the fact that one landmark clinical trial was conducted with the Mycetoma Research Center, with many partners, with support from the NDI.
Unfortunately, the interpreters cannot hear the speaker.
On behalf of the mycetoma patients, their families, and their communities in remote areas, I would like to express my sincere thanks and gratitude to DNDi for supporting us to support the patients. The DNDi has made a lot of effort to make the mycetoma known to the international communities, to the international research centers and institutes, donors, and funders. The NDI had a lot of effect on our work in the mycetoma patients' activities. The NDI had supported the first ever double-blind clinical trial for mycetoma treatment. The NDI had trained us to do a proper clinical trial. I was trained by DNDi in doing a proper research for these patients. We have the best ever lab for mycetoma diagnosis supported by DNDi. DNDi has supported us to establish the peripheral satellite centers, the labs, the ultrasound machines, and other activities in the field, the trips, and the campaign to see patients at the level of the field and to treat them there. The NDI has supported a lot of my colleagues for training in good clinical practice, laboratory practice, and even in financial practice, and how to conduct and to administrate a proper clinical trial activities. I cannot say how we are grateful in Sudan for the NDI for making us coming to this point and be here in the WHO today. And without the effort done by DNDi, I was not be able to come to this. I'm not able to come to this event and to be part of this community of researchers. Definitely, the DNDi had impact on not on Sudan, on different people in different parts of the globe with affected with mycetoma and other neglected tropical diseases. Currently, we are having 3 projects with DNDi running nicely, smoothly, and I'm sure the result will be of great help for the patient and the communities and health system where mycetoma is endemic. I'm very grateful for this lady. I call her the mother of mycetoma because she is the one who put the mycetoma in the agenda of WHO priority list and the DNDi agenda as well. So thank you very much for this.
Thank you. Thank you. This is really a very touching moment. I really appreciate DNDi colleagues for thinking about this award and recognizing Professor Fahal in this occasion. We are also delighted. We didn't plan it. It was not in our agenda, but it's a surprise, but a nice surprise. Really, thank you. The Mycetoma Center, Professor Fahal has been, an outstanding and passionate person with regard to his center. He has met and advocated for the cause of mycetoma and for those horrible, disease and for those patients affected by this horrible disease for a long time. The first time I went to Sudan for a leishmaniasis mission, he took me from the WHO office to show me in the Mycetoma Research Center and take me around, to see how, this patient, this community are affected by this very bad disease. So he has advocated in all international forums. He has sent all his books and all these, pictures to all directors of the NTD department before mycetoma was recognized. Thanks also to the support of the MSF and the NTDi colleagues who helped a lot, advocated a lot for making mycetoma a global agenda. Now, since 2016, mycetoma has become a global agenda. Since then, also, a lot of progress has been done on the clinical trials. Recently, we have developed the target product profile, which may address the question from Professor Jean with regard to the diagnostics needs to differentiate actinomycetoma from eomycetoma. So we really appreciate your service as a WHO collaborating center, and also the Mycetoma Research Center is not providing care only for patients in Sudan, receiving patients from Ethiopia and other neighboring countries, even from Chad. So that is really appreciated, and it is the only center that is keeping a registry of all the patients treated in the center for so many years. So this is also another exemplary work. And the center is providing and supporting WHO in rendering clinical case management for countries even outside of Sudan, like Pakistan and etc. So we appreciate your service and contribution, not only nationally, but also regionally and globally. Please continue, and this reward is well deserved. Thank you.
Come to the center for the last photo.
Daniel, we need you.
Whoever wants to join, please join. Celebrate me.
okay, it's okay. It's okay. Thank you.
Merci beaucoup.
Thank you very much.
Thank you so much.
Yeah.
You know, it was just, on a trouvé l'occasion, on s'est dit, allez, parce que c'est vraiment...
Merci beaucoup. Merci beaucoup.